everyone, my name is Julissa and I am the Community Care Coordinator for the program Bridges to Health. In this video, I'll be talking about healthcare coordination in the Latino migrant farmworker community and ways we can all work together to create a more equitable health system for these individuals. So to start off, who are the Latino migrant farmworkers of Vermont? These are migrant farmworkers who immigrated to the U.S. to work in agriculture. Many of these Latino migrant farmworkers are from either Mexico or countries in Central America, such as Guatemala. Most of them are young men with low formal education, often only having graduated middle school, with low income and speak little to no English. Most speak Spanish as their first language, but some speak a local indigenous language as well. These individuals also do not have traditional work hours. Many work long shifts, often 12 hours in a day, and usually only have one day off to rest. Because of the conditions these migrant farmworkers live in, many barriers appear before them in healthcare. Some barriers are systemic, such as language accessibility at the clinics, especially when calling to make or change an appointment, request prescription refills, or for help navigating financial assistance and billing. Others include costs due to ineligibility for health insurance, implicit bias, and discrimination. On top of these systemic barriers are individual barriers, such as fear. Many migrants are scared to travel and do not drive, especially those near the Canadian border, because they face risk of deportation if they are spotted by Border Patrol agents. Additionally, migrants work long hours, as we know. Many of these hours either overlap with clinics when they are open, or they have their only day off on the weekend when clinics aren't open. And although a health need may be pressing, many migrants may be too scared to take the time off, in fear that they will not get paid for their time off, or in the worst case scenario, lose their job. Finally, there are cultural differences in healthcare as well. In countries like Mexico, for instance, many clinics function like our urgent care clinics in the U.S., in which no scheduled appointment is needed. This cultural difference is hard for many to understand, especially when they are already forced to prolong important health decisions because of the significant barriers they may already face. So, it is for all of those reasons that Bridges to Health exists. Bridges to Health is a program within the UVM Extension Network that works in 13 counties, supporting about 250 to 350 individuals a year. The program's goal is to connect migrant farmworkers to their family members and their family members to health and community services. The BTH team is comprised of the bilingual care coordinator, myself, who coordinates all healthcare needs, and then bilingual health promoters who service particular regions of Vermont, such as the Northwest, NEK, Southeast, and Southwest. Bridges to Health also works closely with the Finger Lakes Community Health Centers, the Rutland County Free Clinic, and especially the Open Door Clinic, which is a clinic that services the migrant farmworker population in Addison County, sharing resources and best practices. Now, let's take a look at care coordination in Bridges to Health. As many of you fill similar roles, you know that care coordination goes far beyond just scheduling appointments. For us, when a worker is in need of an appointment, contact is initiated in one of two ways. The first is that a worker reaches out to me via WhatsApp, a web-based messaging system, or phone calls via WhatsApp as well. The second way is that I hear about a worker with a health need through one of my many coworkers. This could be through one of the health promoters or even an English tutor who has a close relationship with their student. In that case, it's up to me to initiate contact. Then I need to build trust between myself and the individual, reassuring them that I am there to help and will keep all of their information confidential. After that, the patient and I usually try to call a health center together in a three-way call. By calling together, it allows the patient to be more involved in their own healthcare needs and learn a bit more about the healthcare system while I interpret for them. Some workers, however, do not have phone plans that allow for normal calls, only through web-based services such as WhatsApp. Others, due to work schedule, are unable to call with me at all. So in these cases, I call with their permission on their behalf. Scheduling during these calls can be tricky though. Because of the long hours they work, there are very few times when they can go for an appointment, which means there is interpretation and advocating on the care coordinator's part. Then comes the paperwork. We frequently have to fill out registration paperwork and financial aid paperwork. These forms are often in English, which means they need to be translated by the care coordinator. Even when forms are in Spanish, though, workers still may feel uncomfortable filling them out on their own because questions can be complex and they don't want to put down the wrong information. Though infrequent, there are cases where some migrants are eligible for health insurance too. In this case, we will then apply for Medicaid through Vermont Health Connect, which is a tedious and long process due to all of the regulations in place in Vermont Health Connect. This is especially challenging for families who are of mixed status, meaning that some have legal status, allowing them to apply for health insurance, and others do not. Many are fearful of providing incorrect information, and in many cases, members of the family are asked about their documentation status, even if they have indicated that they are not the ones applying for health insurance. For those who aren't eligible for health insurance, we will fill out financial aid applications with them. However, financial aid applications are not always culturally sensitive to the migrant situation. As stated, the majority of migrants we serve are young men who come and live alone in the U.S. But they often send money back to many dependents in their country of origin, including their spouses, children, and parents who depend on this money for their daily living expenses. Many clinics do not qualify this as a household, which means we need to advocate for the migrant for greater aid. Additionally, because they are working 70 to 80 hours a week, a worker who is making $10 an hour on paper looks like he is making $18 to $20 an hour because he is working the equivalent of 2 jobs, essentially. This is not taken into consideration for financial assistance in most cases. On top of this, documentation of income is needed. However, some migrants either use different names that show up on their pay stubs or don't receive pay stubs at all. In these cases, we will try to get a letter of income verification from their boss. Then comes transportation and interpretation coordination. As mentioned, many migrants do not travel nor drive, which means our Bridges to Health clients are very reliant on a small network of volunteer drivers we have. Many of these drivers are older members of the community, and as we saw during the COVID pandemic, having a small number of volunteers has a huge impact on transportation availability. If a volunteer is not available, we try to set up taxi rides for patients, but many don't like this option because the driver cannot offer support at the health center when they arrive, like some volunteers do, and migrants are often uncomfortable or fearful of going with someone they do not know. So the final option for transportation either falls on their employer or on raiteros. Raiteros are unofficial taxi services that work with migrant farm workers. They often speak Spanish, which allows a migrant to feel more comfortable. At the same time, though, some raiteros charge a lot of money, even for short distances. Additionally, some raiteros who are migrants are not comfortable transporting in certain areas due to Border Patrol presence, which further limits ride options. As for interpretation, while some clinics offer interpretation, others do not. And many only offer interpretation with the doctor and not at all points of contact, such as registration, checkout, or billing. This means that I will have to call into a clinic and interpret for the appointment myself when necessary. Then, finally, after all of these steps are accomplished, a migrant has to figure out how to pay their bill. If they did not pay at the time of services, they are sent a bill in the mail. But many don't have bank accounts or credit cards, so they're unable to pay online. They will need support then in asking their boss to pay the bill and have that amount taken out of their paycheck. Or will need support in planning with the clinic to bring in money if they have another appointment in the future. So that was a general description of what care coordination looks like within the migrant community. But now I'd like to give you a real example of care coordination in action. Let's talk about the case of Jessica. Jessica is a child that lives in the northwest of Vermont. She needed an appointment to be able to attend school. She'd never even seen a PCP before in the U.S., so her family was told to bring in the medical records they had from Mexico. However, the physical booklet of immunizations was back in Mexico, not in the U.S. So the family brought in photos of the booklet. However, when they arrived at the appointment, they were told that these photos would not work and that Jessica's family would need to bring in the physical booklet. And without that, they wouldn't be able to make her an appointment. So I reached out to a contact we had in the Department of Health. With their help, we were able to translate and input the vaccination records into the state database system, allowing Jessica to have her appointment. This did prolong Jessica's care, though, and she had to start school at a later date due to this appointment delay. So, how do we move forward and provide more equitable care for migrant farm workers? Some avenues to explore could include scheduling certain walk-in days for migrant farm workers. Through all of my care coordination, I've actually come into contact with some clinics that use this. One clinic in Rutland, for instance, has a certain day and time slot to see recipients of Dr. Dinosaur. And although a certain day or time slot for migrants wouldn't address the diverse work schedule for all migrants, it's possible that I could set a precedent for farm workers in the area to be more lenient on giving days off to farm workers when that walk-in day comes around. On-farm visits are an option as well. Additionally, more coordination could be done between health centers and Bridges to Health on transportation. While health center care coordinators know how to assist in transport needs for health insurance recipients, transportation for those who aren't insured is a challenge. Health centers could maintain a list of trusted and reliable community volunteers that they know of, or support the cost of trusted and reliable taxis. And if there are health insurance navigators at clinics, it would be great to connect and explain the migrant situation. I have noticed that at some clinics, care coordinators will automatically apply for health insurance for migrants before applying for financial aid. This is often a lengthy process that can delay care and delay payment, which results in the bills getting sent to collections. We have a screening process, though, in Bridges to Health, and can work with health centers to let them know if a patient is eligible for health insurance or not. Finally, improved telehealth options would be a great help to farm workers. Telehealth can be tricky because it requires adapting to the technology that farm workers have accessible. But providing this option could take out the barrier of transportation. Most farm workers have smartphones and access to internet, but many do not have access to email accounts. So, health centers can select telehealth options that only require clicking on a link and entering a code to avoid the barrier of not having an email address. They can also make sure that the telehealth option allows multiple people to attend an appointment. This will help ensure that the interpretation company, with whom the health center has a contract, can link their interpreter to the visit. We share the common goal of wanting all community members to have access to high-quality healthcare services. If you are a care coordinator or a health navigator or case manager at a clinic, and you are working with a Spanish-speaking farm worker, I would encourage you to reach out to me. With your knowledge of the health center where you work and local resources, and my knowledge of how to navigate healthcare for this unique population, we can work together to provide better care for farm workers. In many cases, I'm already working with the patient and know their particular situation. For others, though, we can easily gain needed information by speaking directly with workers in their native language. If you have any questions about the population or a particular patient, please reach out to me. I can be contacted through email at julissa.vesely@uvm.edu or through my work cell at 802-503-2301. Thank you.